Good afternoon, everyone, and welcome to today's webinar discussing participant recruitment, retention, and strategies in the Black community. I'd like to thank you all on behalf of the Council on Black Health, formerly known as the African American Collaborative Obesity Research Network, ACORN, and the Center for Diabetes Translation Research at Washington University, St. Louis, for your participation this afternoon and interest in this topic. During the presentations today, we ask that you post questions using the Q&A button in the Zoom webinar interface. We will review and select questions for our panelists to respond to after their presentations. If your question was not selected for response, we will share follow-up feedback after today's session. Please feel free to use the chat window as well to interact with fellow attendees during the session. This presentation will be recorded and archived for future viewing. We will publish the webinar online and share the link via email later today. My name is Sheldon Oliver Watts, and I am the National Director of the Council on Black Health, also known as the Council. The Council is the new identity for ACORN, a collaborative network of scholars and community-based research partners located in over 20 different states. The Council's mission is to develop and promote solutions that achieve healthy Black communities. Our national office is located at Drexel University's Dornsife School of Public Health in Philadelphia, Pennsylvania. The Council leverages the credibility and perspectives of Black American researchers and research partners to facilitate more relevant, community-engaged, high-impact intervention research. I'm also the core manager of the Solutions to Diabetes in Black Americans Core at Washington University's Center for Diabetes and Translation Research. As a disparities core, we provide methodological and content expertise to develop innovative approaches that advance the field of diabetes research in Black Americans. In today's webinar, we'll be discussing how, compared to other population subgroups in the United States, Black Americans are at a higher risk for chronic disease, including diabetes. Research has demonstrated that recruiting racial and ethnic minorities into research studies can be challenging. Some of these challenges include fear and/or suspicion of research institutions and their motives, difficulties with the recruitment process because of narrow eligibility criteria, cultural factors, influence of family members, emotional stress, inconvenience, and difficulties with establishing appropriate community partnerships. More novel, labor-intensive, and simultaneous strategies are required to recruit African Americans. During today's presentation, we will discuss strategies for successfully recruiting African Americans and African American organizations into health-related research studies and programs. Our discussion will include barriers to and facilitators for successful recruitment, as well as best practice suggestions for recruitment strategies. Our respected panelists today include 3 speakers who will be sharing their perspectives on recruitment of African Americans into research programs and for community-based actions. Dr. Melissa Whitglover, President and CEO of Gramercy Research Group in Winston-Salem, North Carolina. Gramercy Research Group's mission is to positively impact and improve the lives of individuals and communities by addressing health and health-related issues. She is also Executive Director for the Center of Excellence for the Elimination of Health Disparities, SEED, at Winston-Salem State University. SEED strives to promote health equity and social justice in healthcare delivery, treatment, and outcomes by leading collaborative efforts to generate and disseminate evidence-based policy-relevant solutions, and to educate future leaders on how to deliberately consider and incorporate equity and social justice in professional practice. For over 20 years, Dr. Whitglover has been engaged in research and evaluation projects designed to identify effective strategies to promote adherence to national recommendations for physical activity, diet, healthy weight gain, to address disparities in chronic disease morbidity and mortality. Cheryl Emanuel is the Senior Health Manager for the Office of Community Engagement at the Mecklenburg County Health Department. She has given 32 years of her professional career to public health and community development, leading and managing health promotion prevention initiatives with a focus on improving the health and quality of life for racial and ethnic minorities through policy development, community engagement, program implementation, access to care, and resource dissemination. She has been a consultant for the Research Triangle Institute Health and Social Policy Division. In her role with Mecklenburg County Health Department, she is responsible for identifying and implementing strategies for reducing disparities and increasing health equity, including leading the Village Heartbeat program. In 2016, Village Heartbeat was awarded the Community Outreach Champion Award from the CDC Million Hearts Initiative and was selected as part of the Healthiest Cities and Counties Challenge. Ms. Emanuel shares a deep passion and commitment to serve the most vulnerable populations, regardless of race, gender, age, or socioeconomic status. Finally, joining us today is Marcus Murray. Marcus Murray is the Executive Director of Project Brotherhood, a Black men's health clinic which he co-founded in Chicago, Illinois, 2 decades ago. Mr. Murray has been a community advocate for men's health for over 20 years. He has presented over 100 national public health publications discussing the health of Black men before national government, state departments, local community audiences, and public health conferences. Mr. Murray and Project Brotherhood were featured on CNN's Black in America 2, Today's Pioneers, highlighting the organization as a solution to many of the problems faced by Black men in healthcare. Project Brotherhood is a nonprofit community health organization focused on using outreach and preventative education to meet the needs and improve the health of African American men nationwide. Mr. Murray has received numerous awards, including the Jim Wright Public Health and the LISC Community Hero Award, Martin Luther King Dream Award, and noted by the Center for Disease Control as one of the top programs for chronic disease prevention and health promotion. Marcus Murray is considered a national leader in the area of Black men's health. Most importantly, he's a loving husband and proud father and continues to be an advocate for social justice. I'd now like to invite Dr. Glover to open our presentation today with a talk on the differences in physical activity. To open our talk today with a discussion of 2 projects that are directly related to recruitment and working with Black Americans in community-based settings.
Great, thanks, Sheldon. So I'm going to talk about 2 projects that we did. Again, one focused on working with churches and the other focused on working with recruiting African American men. And I'm not going to share any results from any of the studies. I'm going to share information about how we recruited the populations. And I titled it, if you're at the end of your rope, tie a knot and hold on, because I've been asked to speak several times about this topic, particularly for groups who are having some challenges with recruiting what we call hard to reach populations. So, okay. So the first project I'm going to talk about is called Ladies, Learning and Developing Individual Exercise Skills for a Better Life. It was funded by the National Heart, Lung, and Blood Institute. Just briefly so you understand the project, this was the study design. We were recruiting churches and liaisons within churches. Within those churches, we were recruiting study participants to engage in a program. We collected data. It was a randomized controlled trial, but we screened and enrolled study participants before we randomized the church into one of 3 conditions. And we did that to try to ensure that churches all would participate regardless of the condition. And you can see there are 3 arms. One was a faith-based physical activity curriculum. The other was a secular curriculum that did not include faith-based information. And then the third was a self-guided control condition where people received information and they implemented that on their own. Both of the interventions were 10 months long, and the control participants had 10 months to go through their materials. So we collected data at baseline and then 10 months, and then we had a 1-year no contact period, and we collected data again at 22 months. So it was a fairly long study that we were asking people to commit to. I'm going to just skip this part other than to say what I want to say about this is we talk often about having people who are part of the community engaged in developing the research. And so the folks who were study investigators were myself, and then we had a local pastor who was the co-principal investigator on the project. And so he wrote the faith-based content, but also helped us to engage with churches. And then we had a community advisory board that consisted of ministers, deacons, church lay educators, and people who were past study participants. And we did that deliberately to try to make sure all the voices of people in the community were heard when we were developing our materials as well as our recruitment strategies. Sheldon, Okay, I was going to say that the screen's responding slowly. So who could participate in this project? Churches had to be predominantly African-American serving churches in the county we were in, which is Forsyth County. They had to have a pastor who was committed to the program, but also willing to accept a random assignment to a study. And we needed to make sure that the pastors weren't going to say, we only want to participate if we get the faith-based curriculum. The pastors also needed to identify and appoint a site captain, and that person was the liaison to help us recruit women within the church. So they knew who the women were in the churches, and they saw them on a regular basis and could get in. And so we recruited churches, and then site captains within those churches recruited participants. Within each church, participants were African-American women, who were, we recruited 12 to 15 women per church, African-American adult women, not regularly exercising, but who were able to engage in physical activity. And we were looking for 20 to 30 churches, and that number, it looks like that because we originally were trying to get a larger number of women per church, and we ended up reducing the number of women per church. And in order to maintain our study power, we had to increase the number of churches. So we were looking to impact about 450 women. So this was our recruitment strategy. We, again, met with people in the community and really talked about how do we get this work done. And so we spent a year planning and creating recruitment materials, and we had some very nice flyers and materials to get women within churches engaged. We had our strategy for recruiting churches was trying to get to the churches, connect with someone at the church, get them interested in participating in the study, and then the bulk of what we did in terms of recruitment materials was how do we convince women to participate. What we found as a study staff, and our study staff was all African American, all with background working in churches, and again, I said we had a pastor who was involved. Our study staff did the bulk of the recruitment at the beginning, and we, out of the 30 churches that we needed to recruit, we were able to recruit 3 churches in 10 months, and we were, and it was not for lack of trying. We had direct mailers, flyers, we called the churches, we did pop-up visits, we tried to go when they had Bible study, we went to a local ministers conference, we met with people who had participated in a previous health ministry institute for us. We did everything we could think of to get access to the churches. But despite our best efforts, we recruited only 3 churches in 10 months. And so then the next thing we did was we decided to try to identify some folks in the community who were from here who had more of an inside track to get to churches. And so we recruited hired some insiders as consultants, and those individuals, there were 7 of them, they recruited 28 churches in 4 months. So again, that previous slide, it took us 10 months to recruit 3 churches. It took people who were connected to the community 4 months to recruit 28 churches. They didn't have any materials that were different than the materials we were using. It was just that they knew somebody in the church to connect with directly, to actually get them to the people who could make the decisions about the church, whereas we were kind of going to the front door and hoping somebody would open it, and that wasn't always the case. So we attempted to recruit 69 churches, and you can see we made contact with 48 of them, and we were able to enroll 31. Some of them we couldn't reach, or when we finally reached them, they weren't interested. There was a small number of churches that were interested, but they just couldn't get enough participants, but that typically wasn't the problem. It was more so we couldn't reach them, or we never ever got, we couldn't reach them for further follow-up, or we never got them. So we enrolled 31 churches. 11 of them were enrolled by our research organization. 20 of them were enrolled by our community recruiters with the inside track. This just shows you the description of the churches that were involved. So we had 31, and you see 2 stars at 14 and 27, and that's because 2 of the churches, which happened to actually be larger churches, had trouble recruiting enough participants, and that was because we limited participation to only 15, and because the number was so small and the congregation was so large, they were uncomfortable making general announcements for something that everyone couldn't take advantage of. But what you can see here too is the number of months that it took us to recruit churches, and you can see this ranges from 0 months to somebody, as soon as we called them, they were ready to sign up, or they called us to sign up, all the way up to 9 months of, you can see here, it took us 9 months of going back and forth and trying to set appointments, trying to get in touch with the right person, trying to to get scheduled, to get on the pastor schedule. And so the lesson learned there is recruitment time periods have to be long enough, especially if you're trying to engage community organizations. They have to be long enough for you to really be able to accomplish that, because it's not, people aren't knocking down the door to participate in research. So on average, our church recruitment took about 3.5 months for each church on average to recruit. You can also see here just an idea of who the person was that we contacted, and it wasn't always, or who our contact person was. It wasn't always the pastor, and in many cases, it wasn't the pastor. So probably about half of the churches, maybe a third of the churches, it was the pastor. But then, and then in one case, it was the pastor's wife. But for the most part, there was either some health ministry leader or coordinator or someone in the church congregation who brought it to the church and said, can we do this program? And I think that's important because we do a lot of research with churches, and we always say you have to contact the pastor. And we found that the pastor needs to be on board, but a lot of times that's not the person who's there, you know, on a day-to-day basis, who's making these kinds of decisions. So you have to know how to connect with other people. You can also see here that when in terms of the prior relationship with the research organization, several of these churches did have a prior relationship with us from participating in previous programs. We are a research institution, and so while we do have contact with these churches, and when they reach out to us, we do try to provide whatever they need. So if they need a speaker or someone from for a health promotion activity, we try to participate, but we aren't with them on a day-to-day basis. We are not as connected as folks who do community-based programs. And I think from a research perspective, that can hurt you. And so it's just so important to have other community partners who are connected, who can help you engage with the communities, because when you're doing research, it's hard to have that, maintain that relationship with your community organizations that you're trying to recruit. But if you want to continue working with them, you've got to figure out how you're going to be able to do that. And so that, you know, I've kind of talked about those lessons learned. So know your community. In our community, what we found out is it was more important for, you know, we had African-American staff who were trying to recruit churches with church background, but what was more important in this community was people who were actually from this community. And so it didn't matter that we were race matched and that we were matched in terms of faith background. What mattered more was those insiders who actually were from this community. I talked about the importance of insiders. We had spokespeople who spoke up for the program, and once people in the community saw those individuals, they were willing to participate, and it didn't matter what kinds of recruitment materials we used. It had to do with who was vouching for the program. The next study I'm going to talk about in my last few minutes is Active and Healthy Brotherhood. This was funded by the Patient-Centered Outcomes Research Institute. This project is focused on reducing chronic disease in African-American men. And what we know from research is that African-American men tend to have higher rates of chronic disease, healthy lifestyle behaviors that are less in the positive direction in terms of meeting recommendations. And so as a result, Black men have a lifespan that is 7 to 9 years shorter than others. And so we wanted to examine what an active and healthy brotherhood intervention would look like for African-American men. And you can see the two arms there. The intervention was 16 weekly sessions with 3 booster calls that happened over a 6-month period. And the self-guided condition was self-guided materials that participants got. Data were collected at baseline in 6 months, and then we did 6-month monthly mailers, and then we collect data at the end of 12 months, so 3 time periods. Participants were self-identified African-American adult males, originally living in Winston-Salem. They had to be at risk for developing chronic disease by not meeting national health guidelines, and they had to be able to participate in the study from a safety perspective. We worked with a large team of African-American men to develop the messaging for our recruitment materials, and you can see here are two of our primary flyers that we used. We talked about Your Life Matters, and we presented it from the perspective of who African-American men are. I'm a friend, I'm a father, I'm a brother, in a way trying to make sure that the messaging related to health resonated with men. So why you should take care of your health is because you're a friend, you're a father, you're someone's brother, and we need you around. We also used pictures of African American men engaged in health as a way to help us recruit. Once we spent a long time doing recruitment, and so we got to a point where everyone in the community had seen the Your Life Matters flyer, and so we worked with our community group again to switch the flyer around to have a little bit different messaging about, do you think about how to live a better life for yourself and your family, again with a way that hopefully would resonate with the men in terms of what's important to them. Maybe not health for itself, but maybe it's health because you want to take care of your family. So those were our two main flyers. We also talked to a group who had been working with Latino men, and they were using some of these, I don't know what you call these things, some of these sort of larger flyer things like this in public places to for messaging for working with Latino men. And so we used something similar for African American men, and we could set them up so they could be seen widely when we were at recruitment events. So how did we recruit participants? We realized we had to be prepared to think outside the box. So what we realized when we were trying to go out and recruit African American men, at least in this community, is that there were limited opportunities to engage large groups of men. And so after you think about churches and barbershops, there are very few places in this community where African American men go and congregate, and so we had a hard time trying to figure out how we could reach them. And so we did everything you can think of, every event that they had in the community, we were there. We did advertisements on radio, television, the news, churches, social organizations, direct mailings. We put magnets on our cars advertising the study. We offered a referral fee for participants who were a part of the study to recruit participants. One interesting thing about that is we were very clear with our participants that it was an intervention in a control group, and we needed to maintain that, so participants weren't supposed to share information from the intervention group, but they took it a step further and wouldn't share any information at all about the program because they were so concerned that they might mess up the study. In terms of online engagement, we couldn't just put ads out for online engagement. And so these are some of the online engagement ads. We try to be very thoughtful about how we put things out in social media. And so we try to, again, come up with things that would resonate with men. We use the Facebook boost option to be able to directly target our ads to people. What we encountered as a part of while we were doing our work is Facebook really started cracking down on targeted ads that seemed like they might be, against or for a particular race. And so a lot of times our ads would get rejected because it looked like we were, we could have, I guess looked like a hate group. We got a lot of comments from people on Facebook about us being a group and why we were only focusing on African American men, which was an interesting thing. This was actually one of our more popular Facebook posts. So we were reaching people. You can see here we reached 10,649 people with this post. And I think because people were really encouraged by the statement that said, yesterday you said tomorrow. Unfortunately, we got a lot of people's attention. They didn't sign up for the research study. We also ended up expanding to another city or to 3 other cities because we couldn't get enough here in our community. And I neglected to say we were trying to recruit 400 men. And so you can see all the different kinds of partners. You can see we started appealing to men. We need your help. Please help us. We are trying to really get men engaged. And so we did everything you can think of. Some of the things, just real quickly here, some of the things we realized is we asked participants to complete a survey called the Holmes and Rahe Stress Scale. And it's a survey that basically, depending on the number of events that you check in terms of things that have happened to you in the last 12 months, that's kind of a predictor of your risk of breakdown. What we saw not only in our participants, but also in our recruitment team is over 50% of the people who we are trying to engage and who are doing the engaging are at high to moderate risk of a breakdown. So we're trying to engage people who are dealing with a lot, and we're people who are dealing with a lot. And so, it's very difficult to recruit people. You have to be very patient if you think about the things that could impact people's lives, and you're asking them to participate in a research study that may or may not help them. So I just thought that was an important point. While we were recruiting, lots of things were going on nationally. Lots of things were going on in our local communities that were impacting Black men. There were lots of protests in every one of the cities that we were recruiting in. There were local events in 3 of the cities. There were instances of police shooting unarmed Black men in at least 3 of the cities. One of the cities had a flood, and several of the people who were in communities we were trying to recruit lost everything. And so there were lots of things that were going on while we were trying to recruit for this research study. I'm going to skip this other than to say the bulk of what worked in terms of us recruiting was recruiters going out to just any place they could find to recruit people. You can't see this slide very well, but I will say we made contact with 3,776 men in order to get the 333 men that eventually signed up and completed the first part of our study, which was the baseline visit. If we could get men to come to an information session, then you could see our numbers increased in terms of getting people through. But we only had, out of the 3,700 men that we reached, only about 25% of them were eligible. So lots had to happen to get these men in. We continue to call our participants on a regular basis because we have to do just as much as we did to get them in, we have to do that same work to keep them in. It's been difficult, but it's absolutely worth it for us because we're a part of the community. When we see these men in the community, they are grateful. We are grateful for them. And so it's not easy, but it's definitely worth it. And for us, what we always try to think about in our work that we do for our firm is to do no harm and to leave the world a better place than we found it. And so if that means that we have to do a little bit extra for our participants to make sure they're able to participate, then it's worth it for us to do it. So just a final slide, just to acknowledge my amazing research team, and thanks very much.
Thank you very much for your insights on this topic, Dr. Glover, and for your interesting ways of presenting how we should kind of think about this process, especially as it relates to working with these very complicated populations in these very complicated communities. So I'm going to now turn to Dr. Miss Emanuel, who will be discussing the Village Heartbeat program and developing strategic faith-based partnerships.
I'd like to say good afternoon. My name is Cheryl Emanuel, and it's an honor to have the opportunity to present this afternoon. I'm probably going to come from a similar place where Dr. Glover just presented, but maybe more grounded, being one that has the experience working what I call in the trenches of the community. So the very first slide, we have an initiative in Charlotte called Village Heartbeat. And the BEAT stands for Building Education Accountability Together. And one of the things that I believe truly there are deep roots within our community. And so what I like to say, when you look at a big, huge oak tree, there are many branches that's a part of that tree, but truly for that tree to have grown, there had to be certain seeds on good fertile grounds for that tree to grow. We may bend, but if the soil is strong, we won't break. So the next slide I'd like to talk about is strategies for building trust and transparency within our communities. I believe it's so important that before you even begin to engage, we need to understand what our own strengths and challenges are before we can do community work. And I think when you work in a community, you have to be willing to understand what are those comfort zones that you have, what are those uncomfortable zones that you may have. Because when we are walking and treading into community, truly there's turfism and there's intimidation factors that you need to think before engaging with the community. So the next slide, I also think that's very important when you're thinking in terms of working or doing research in communities. I think it's important to understand that the head will indeed battle the heart. And I'm going to talk more about that as I proceed through the presentation. We often know that there are things we want to be able to do, but if you're really doing the work to really make an impact, your heart has to drive you to really understanding that if you are going to plant those good seeds, you got to plant them in good fertile grounds, and I call those deep roots. If not, they're not going to grow. So there are a few questions that I'd like to just propose for us to think about. One being, what am I willing to see? Where am I willing to go? Who am I willing to engage? What am I willing to speak up for? And what am I willing to risk? So, so when you think about this particular slide here, I just did a quick snapshot of the area that I work in. Again, working in communities, I think you have to be willing to look beyond the beautiful skylines that are in your community. And you have to understand that all communities have relevant history, and you cannot discount it. And I think you have to put some deeper lenses on in order to come closer into our communities. So I want to talk about a little bit in the next slide. As you begin to look to see in the communities, there are certain things you've got to figure out about the community that you're working in. And I think one of the critical strategies is definitely mapping, getting an idea of where you want to engage, and just not mapping what I call big areas in your communities, but really kind of mapping all the way down to the blocks in your community. You can begin to learn a lot that resides in those communities. So the other question I want to talk about is, where are you willing to go? You know, a lot of times when we look at the data, we understand what the data is saying about our community. And but if you're not willing to go into these communities, then it's going to pose challenges for you to be authentic and genuine working with the population. So there's a concept that I like to use, and it's called the penny syndrome. And what we have learned about the currency in America, we see pennies all day long, and many of us walk by those pennies. But if you got 99 cents and you're short $1, you need that penny to make that dollar. And that's similar to people. We see people in our communities all day long, and we walk by them. And you can't make a difference until you begin to have a heart to engage them in. And this particular slide, these are zip codes in our community that's for many years, they paralyze around the same with crime rate. We know where they are. We know that our people are dying, but we got to get in there and figure out what's working and engaging with individuals. So the next question, again, I just talked about that to kind of push through, is that we have to be willing to map. There are certain communities that we can go in, and you can go through the door might be open, and there are other doors that may not be open so quickly for you, but you got to be willing what kind of skills you have, that sometimes you have to be willing to be genuine and help open other doors in our community. So this is a slide that I like to say here. Again, the question is, who am I willing to engage? And that's again around penny syndrome, and I call this the rules of opposite. There are people that we see. We don't take the time to engage them, but a lot of times you have to figure out for you, do you have that heart? And I truly believe that only way you really make a change with programs, as individuals, our hearts have to break to feel the hurt that we see people in our communities, and figure out a way how you have conversations with them to be to get them. So again, not discounting. I think sometimes when we want to do work in our communities, we tend to want to be in safe places or safe zones. But in order to see traction happening in our community, you got to be willing to engage with people that you ordinary may not want to engage, that I believe. And these are some of the ideas that I just wanted to remind us every day, that you got to figure out what kinds of conversations you would be willing to have, and what would they sound like, and whether you would be comfortable as individuals having the conversation to reach people. So this is a little bit about the project. These individuals that you see, this is a part of our initiative that we have with Village Heartbeat. So we've been able to engage faith-based organizations. I started with 7. churches in 2013. Today, I have about 49 churches that are participating in the initiative. And again, I think with our project, again, I believe it's so deep-rooted in the community. And these are just what I consider a few of the good seeds that you have to be willing to consider planting. And one of the biggest ones that I put that sneaker on, you got to spend some time, what I call sweat equity. You got to spend some time out there so that you can have some credibility, or either, as Dr. Whit Glover said, identifying individuals that can help you entree into a community that have those sweat equity. But also, once you be willing to get into communities, you got to be willing to not just let it be all about your program, but creating opportunities where there's shared purpose and shared power. And people have to realize that you are willing to look out for them, and not just all about you, about us as being our program. And it's so important to keep it real. And the work that we do in the community, you got to be willing to have the endurance. And eventually, if you got the endurance, I do believe trust will eventually begin to occur. So with this slide, I'm getting ready to talk about something that I think has been created for our project. And it's the word competition. So with the work that we're doing with Village Heartbeat, I like to say there are multiple components in the project, but there are two pieces that we have identified that are significant pieces of our initiative. One, there is something about competition that motivates us as African Americans, not just think as people in general. So we added a competition component in order to begin to engage faith-based organizations. They compete for 16 weeks in a challenge to look at lowering key risk factors around cardiovascular disease. And we have both African American congregations as well as African American churches participating in the project. And so there's something about competition, again, that I believe that motivates us to be important. So when you think about competition, you see the word out there with gamification. And so with our initiative for those 16 weeks, we are involving them in multiple strategies, multiple activities where they gain points. And at the end of the 16 weeks, we create a red carpet experience that we call the Hearts of Championing Gala. And the individuals, the churches are actually awarded a first, second, and third place. And individuals that improve on those biometrics are also rewarded opportunities. And I have in this slide, too, in terms of working with the population, is that you have to identify trusted leaders. So with the competition, when it's occurring, we have created what we call the Teresa Elders Community Health Leadership Academy. And creating that academy after a person that's rooted in the community means a whole lot, because then your project is also going to leave a legacy behind with somebody that perhaps name had never been on anything in the community. So I think that's extremely important. And again, I think it's so critical that whatever we create, we try to create that we leave something behind. This is a little bit that I'm going to move on real quickly. Again, utilizing competition. The other piece I like to say, this is the last slide, when you're thinking about working with communities, I think you have to be willing to intentionally connect to something that's larger to the community. So with our initiative, it's been extremely important for us to engage participants that had never participated in our MLK parade. And so with them being able to, with us connecting to something bigger, we not only were able to introduce them to something to get involved in our community, but it also helped them to signify a way to have pride. And the other piece with our initiative that I failed to mention when I was talking about the gamification, also I think you have to begin to look in your systems. What other opportunities that you are aware of that perhaps can also be able to move groups that you are working with so that they can benefit also from additional funding or resources. So with our project, with the churches that we have been able to engage, we also have another strong component that's been added. I was able to discover what I call opportunities in our county government system to help our churches become vendors for our county. And just being able to teach my pastors how to move through the procurement process, it has meant so much to them because now they understand very fully. I am beginning to teach them how to also be able to compete against nonprofit organizations or programs that they may want to do inside their communities or inside their church. But in reality, our faith-based initiatives, our pastors, they have individuals in their church that also can lead these initiatives. So it's important to teach them how to be able to fish so that they also can stand on their ground, not just us creating programs or always bringing our own nonprofits in to do work where you can teach other people to also be a part of creating change and sustainable change. So this concludes my part of the presentation, and I look forward to answering questions. Thank you.
Thank you so much, Ms. Emanuel, for sharing your efforts in Mecklenburg County and really talking about that process of having the organizations look for that change internally in terms of bringing to bear what they would like to see in their communities. So now we'll hear from our final speaker, Mr. Murray, who will share his insights on Project Brotherhood.
Good afternoon, everyone. So Project Brotherhood, a Black men's clinic. What is it? What are we doing? How do we engage men? Before we always give presentations, we just like to tell stories about really what goes on. There was a 20-year-old Black man who was coming home from college, and he was having chest pains. So he went to one of Chicago's well-established hospitals. It was a public hospital, so, he was still on his parents' insurance. He didn't know to go to a super-duper fancy one. So while he's waiting there, since it was a public hospital, you have a lot of different races, a lot of different backgrounds, all waiting to go up. So he waited for about 2 hours to figure out where he had to go, and then he went up to cardiology. So at cardiology, here's this little 20-year-old Black man sitting in the room with people approximately, 50, 60 years old, older in life. He's sitting there nervous, doesn't know what to do. So after about another hour and a half wait, he finally gets to go to the back. Once he gets back there, he sees a doctor that doesn't look like him, can't understand him. The communication was gone, and the doctor came in the room and said, don't drink, don't smoke, don't have sex, and come back in 2 months. So, of course, people assumed the young man would come back, but as the young man was telling us, he was scared. Why come back? Why should I have to sit there and wait 3 hours just to see the doctor? This doctor didn't ask me, he didn't even ask me if I drank or smoked. He just assumed it. There was no communication, there was no trust, there was nothing. Later on in life, that young man grew up. He had his first heart attack, I believe, when he was 24 years old, and that was the next time he actually entered a healthcare facility. So the doctors and nurses and administrators from Cook County Health and Hospital System are witness to these type of stories all the time. So what they decided to do is say, hey, let's create a program where Black men will feel comfortable to seek medical care. And while they're there, we can help them with other things. So the basic fundamentals of Project Brotherhood is like mission, not necessarily our mission, but how we look at health is this first slide. What is health? I won't read it because we have it recorded, but I just highlight certain things. Health is a social, an economic, and a political issue. And most of all, it's just a fundamental human right. So everybody has the right to access to care and to be healthy. But if you look at the last sentences, this is the most powerful part. It says that health, the powerful interests need to be challenged. That means these healthcare systems, these hospital systems, these politicians, they have to be challenged. The healthcare system right now is set up not to cure people, it's set up to control people. If you understand that there's a lot of money involved in the healthcare system, then you understand that people aren't really trying to control it. Although we might not assume that the general brothers on the street don't know this, they do know that. So when you go in there trying to talk to them, you have to be aware that they're aware of things that are going on, they're aware of their body, and then it comes in with the lack of trust. So what is health to Project Brotherhood? So the Project Brotherhood, we basically adapted the World Health Organization's definition of health. So health is not simply the absence of disease, but the presence of physical, mental, social, economic, and spiritual well-being. Why is that important? Because if one aspect is off in a brother's life, then you can't really treat that brother. For example, some of our diabetic men might come see one of our Project Brotherhood medical providers. If they're not taking that medicine, our doctors won't put down that they're a non-compliant patient. They understand the other factors that might be involved to determine whether or not a man is going to be on his regimen for whatever chronic disease he's suffering from. Who does he live with? Does he have a job? Does he have insurance? How many kids does he have at home? Does he have healthy options for food? Because if a brother doesn't have a job and can't pay his bills, he might not have a refrigerator to keep his medicine in. He might have to make a choice of buying some Popeyes, and I have nothing against Popeyes. I like Popeyes, as opposed to eating some healthy food choices. So when you address a man's physical health, you have to definitely look at all the other aspects. Now, you know, us health professionals will say, yeah, it's the social determinants of health. We throw these terms and words around all the time, but do we really actually live by it and know what they mean? So if you look at the next slide, now this is sad. In 1998, this slide was basically the same as it was in 2008. The 5 leading causes of death for Black men are basically preventable. You know, I'm not going to go through each one, but for example, heart disease, that has to deal with exercise, eating right. You know, a Black man running around on the south side of Chicago, it's a good chance you might get shot. And it might not be by the police. It might be by another brother. You might get chased by a dog. The moral to the story is it's not safe for Black men to exercise out in public. Our parks in the neighborhoods and inner cities aren't safe. We can't go there. When you think about food deserts and things of that nature, brothers aren't getting good food. They can't eat. One time in Project, and all these things come on and say, oh, Black men, you need to eat healthy. You need to do this. You need to buy fruits and vegetables. We did a survey one time. Black men didn't even know the difference between fruits and vegetables. Why? Because they weren't the primary shoppers in their house. The second thing was they didn't even know how to prepare fruits and vegetables. How do you pick them out? When are they ripe? When do they go bad? So a colleague of mine once said too, it's not just about introducing them to the food, you have to change their palate. But how many funders are going to allow us to really have cooking demonstrations and things of that nature? And when the grant's gone, how are you going to be able to sustain that? That's a whole nother talk. So if you look at homicide and things of that nature, we're all professionals. We all know people need jobs, housing, and things of that nature. And that'll help prevent, it won't eliminate, but it'll help prevent some of these diseases. Now here's our logic model. I won't go through everything in the logic model, but I'll pick out key points. So when we first designed Project Brotherhood, our primary goal was to get Black men to see the doctor. We wanted them to come in and just access health care, and we would provide other services. In order to do that, we had to abandon the old medical model. So we just threw it out the book. And when I say the old medical model, our doctors don't wear white coats. We don't want brothers in there feeling like lab rats. Our doctors might have on Timberlands, they might have on slacks. We have no dress code. Our doctors come out the room and meet the brothers with a firm Black handshake in the clinic area. If our patients need to see a social worker, we don't use navigators unless we're real busy. Our doctor walks down the hall. Now, you know what Black folks think of doctors in the hood. Doctors and lawyers are the highest thing in the hood next to preachers. Doctors are especially looked up to because they save lives. So when you have a doctor that's walking out his exam room and transferring a patient or introducing the patient to a social worker that can now help him with his social needs, that man is like, wow, this is amazing. Because most of the time we're given a number and a referral and say, go here and go there. And that human touch is absent. And then we wanted to create a safe place. Yes, we're part of Cook County Health and Hospital Systems in terms of our partnership with Project Brotherhood Lives, but we had to create a safe place that Black men wanted to come to. How do you create that safe place? And I'll tell you in a second. So we want to look at the other factors like, what are we going to do to get these brothers in here? We know brothers got problems with trust. They don't trust the healthcare system. You know, they deal, and a lot of people think it's racism. They also deal with a lot of prejudice from people that look like them. Healthcare systems are designed for women. So in Chicago, there's a lot of gang activity. So when I first started, Black men would come into the clinic asking for condoms. And depending on which way they wore their hat, determined what gang they're in. At the time, our nurses would just kick them off the building. Now here it is, some young brothers wanting condoms. With the HIV rate, I assume you put the box outside and let them grab what they want. But instead, they kicked them out. So we knew that we had to get brothers from the community to help us with this. And one of our ultimate goals was just creating a safe place for Black men, educating Black men on healthcare problems and issues. We didn't want to necessarily force anything on them, but we wanted to tell them about them because we understand their intelligence. So if you tell them about them and let them know how something is, then they're more willing to try it. None of us want to try things that we know nothing about. We don't go to movies based off titles. We go to movies based off seeing a trailer or knowing about it. So Project Brotherhood, this is what we did. We had 11 focus groups with all type of Black men, tall, short, straight, gay, young, old, and we said, why don't you go to the doctor? Of course, we all know the data on why they don't come. But one of the things that stuck out is they said, we want doctors that look like us. We want people that understand where we come from, look like us, sound like us, and won't judge us. We don't want to be judged. And when we started, we had 5 Black male physicians, and we'd always be a place where residents would come through and see patients. Now we're down to 3 Black male physicians and 1 female. The second thing brothers wanted, they wanted other things. They said, look, I'll come to the doctor, but I have some other issues, man. I got this anger management. I might need a job. I need help with a resume. I need things of this nature. So we said, okay, we'll design it around based on what we know we could do, even without funding, what we could do, what volunteers do we have, and what can we do to give you what's called incentives to come into place. We said, all right, one thing we're going to do, and this was all based on the brothers. Now, health professionals will tell you, CBPI, but to me, that's just some garbage. If you want to help people, you have to ask them what they need. We can't assume, because we got degrees and masters and PhDs, that we know what people want. So based on what they said with these other things, we said, oh, man, I got a barber. Let's start giving brothers free haircuts. Let's start feeding them. Let's start helping Black men out with anything they wanted. Now, when we opened up the doors, one of the first things people said is, how are you going to collect information? I personally made the decision, and I'm not saying it was a wise decision, but I made a decision when we first opened up the doors that we weren't going to bombard brothers with surveys and questionnaires. We'll get basic information: where do you live, your phone number, best way to contact you, how old are you, how much do you make, and leave it alone. We weren't going to ask them about their sexual preference, how they feel today, their medical history of their family, because that's just too intrusive. When people stop me in the mall and ask me my opinion on stuff, I don't feel like giving it, let alone am I going to give some stranger a whole bunch of information. But based on the lit reviews that we learn in school, at the graduate school and PhD level, they tell us, well, in order to engage Black men, you have to do this, you have to do that. And we leave out the human touch. So incorporating what the brothers wanted and what we were able to do allowed us to create a safe place for Black men. When we first opened up the doors in 1997, we had 6 brothers. Within that year, we started averaging 85 to 100 Black men in a 3-hour time span. Now, there was about 45 to see the doctor, with about 36 being scheduled, and we always allowed for walk-ins. Why is that important? It's important because most of the time when brothers seek medical services, you don't want to sit in a clinic for 6 hours and you just cut your toe and your girlfriend made you come in. You won't go. Or if you have a bad experience, you won't come back. So that ability to have people walk in and get real-time appointments and lower the actual wait time was crucial. So we served over 40,000 men in our time span. The slide's not working, Sheldon. Okay, thank you. So these are some of the services. Since it's a men's night, we call it Testosterone Thursdays. Men are allowed to be themselves. At the top picture, that's a little old picture, but it's right before the program started. And I wouldn't necessarily, like on paper, our program started from 4 to 7, but men started coming in at 1 o'clock because they felt this was a safe place to hang out. So some of the services that we got funded for, of course, fatherhood programs, manhood development, our social support, where you have 20, 30 brothers in a circle talking about life issues, and they were ran by master level social workers. We had things and topics, but we let it get organic as well. We had guest speakers come in, Chi Young. And the thing at the bottom, what we would do is, the bottom picture was March Madness. So we had 2 screens on 2 sides of the clinics. And during certain breaks of teams that we didn't think were that good at the time, like Duke, no offense to North Carolina people, we might pause the game and let people come in and talk about some financial issues, how to save money. Some of our doctors might talk about the importance of prostate cancer and screening. Like, I just tell a quick story. At this event, our doctors started talking about the importance of screening with prostate cancer. You had 20-year-old brothers talking about, man, I want to get screened right now. We would say, no, it's not ready. You're not ready for it. And one of the things we do as staff members, if we ask brothers to participate in certain type of screenings, we do it ourselves. Remember, it's getting that information. It's building that trust. It's telling them, hey, if I go for this exam, this is what it's like. They need to know how I felt the first time I took an HIV test waiting on those results. So when I give them my story, yeah, it was stressful. I thought about every sexual encounter I had. Even though I was married, I thought about the encounters my wife might have had without me knowing. But me sharing that experience made them comfortable. And then we just start talking and we build a relationship. So how do you engage them? I only have a couple of minutes left, so I'm gonna run through this. All Black men are not the same. Even though we might suffer from the same experience of being quote unquote oppressed, dealing with racism, having certain issues, all human beings go through that, but we are not the same. So when you come to Project Brotherhood, you see different type of brothers. You'll see brothers in suits, you'll see brothers in Timberlands, you'll see ex-felons, you'll see people who've never been arrested. Because we know it takes a village and people can learn from everybody. Even for our staff. Now, we get some in-kind help from Cook County Health and Hospital systems, but the jobs that we control ourselves, we might not give brothers drug tests. Why? Because I want that brother that's not afraid to walk the streets and talk to brothers. It's usually not the type of brother that has a master's. Those are rare, even though we need those brothers with masters. The second thing is we take an innovative and a unique, non-traditional approach. We'll put a basketball hoop in our parking lot. We'll put one up in the summertime because the bouncing of the ball is like an African drum. Brothers hear it from around and they come back there. Then when they realize they're playing with quote unquote health professionals, even though we're average brothers, and they figure out somebody's a doctor, they're like, wow. And then you start talking to them and you're building that trust and relationship, treating them like grown men and treating them with love. Don't rely on those literature reviews. Some of them are good, but they really don't teach you how to engage the community. And a lot of times when we do this, most focus groups and interventions take place in the middle of the day. I have nothing against Willie and Bobo and Pookie from the block. We have some of the same issues, but how you engage unemployed men is not the same as how you engage employed men. Most of the time in research, we deal with a certain population level, or income level, just based on the time we conduct our studies and who we have conducting them. And then understand your population. Understand as much as I believe that you should talk to brothers, you don't need to talk to them like they're research subjects. Talk to them like they're your brothers, like they're your nephews, your uncles, your fathers. Know where you go to recruit them. Churches and barbershops are beautiful. I love them. I recruit from there. I do programs in there. Me, myself, unfortunately, I can't grow hair anymore, so I'm not paying $20 for a line every week, so I shave myself. I'm a very spiritual brother, but I haven't been to church since 1986. And it's not that, I hate the church. There's no desire to go. So now what, you miss out on me, somebody that wants to give back, somebody that might participate in your study. So you have to go to places where Black men congregate, parks, clubs, the gyms. A lot of times people don't even think about youth leagues. You want to recruit fathers? Go to any little youth basketball league or AAU tournament. Don't be afraid to walk to the liquor stores. In Chicago, it's a very big city. We would put our young brothers all the way up to myself, and we would hit the bus stops, the major intersections where people get on the bus, and we would pass out condoms to men and women, just so people could see Black men doing stuff positive. First, I let them wear T-shirts, then I started making them wear shirts with collars. But once the community knows, hey, you like us, you're not afraid of us, you're willing to engage with us, we'll do anything. Like I said earlier, you have to hire brothers from the community. They have to see a reflection of themselves, regardless of how they dress. They want to see brothers that talk like them, look like them, sound like them, and that actually love them. Don't try and sell brothers. Don't tell brothers the importance of this study. Most researchers have to write for tenure and write to keep their job, so I understand the pressure, but if you're selling them, they understand. They watch TV, they have friends. Just because they chose not to do what we do, they understand we get grants and we get all this money, and you want to give us $50 to be in a 10-week study and give up blood and saliva and then come back for other research questions and interviews. They'll be happy to do that. But what you might want to do is say, hey, I could let a group of kids that you know come down to this university and see what a university is like, see what a lab is like. What other things are you giving them? So once you do that by establishing that trust and respect, the sky's the limit. Black men will give you anything they want. They'll be your biggest advocate and everything. And everything we do is based off the CBPI model. We like to call it the FUBU model. For us, by us, and you have to take on a social determinants of health approach and engage in Black men. And if you want to engage men on a study dealing with heart disease or smoking cessation or something like that, you have to be willing to have the resources to help them find a job, to help them develop a resume, to understand they might be in a transitional situation and might not have a cell phone. So you have to hold them accountable for certain things, but you have to understand the barriers that just affects their life on a day-to-day basis. Thank you.
Thank you so much, Mr. Murray, for your insightful presentation about the work that you've done with Project Brotherhood in Chicago, and all of our panelists today for sharing their work both in research settings and obviously in the community setting as it relates to working with African-American populations in inner city conditions, in suburban conditions, in rural conditions, to really advance and support the health of those communities. Now, I know it's shortly after 2 o'clock, and we have a number of participants who are still on the line. But if there are any questions that anyone might want to ask the panelists in this short window that we have, I do think we can maybe answer a couple of questions if people are willing to hold on. Otherwise, you can share questions with me through email, and I can follow up with our panelists and certainly share those with those individuals who participated in the webinar today. And I currently don't see any questions in our Q&A, but certainly will follow up with each of our panelists today to have them share any kind of final ideas, any final talking points that should prove beneficial in terms of recruiting and potentially retaining this diverse community as it relates to the research projects or the health improvement projects that we're mounting in the Black community. So I'd like to thank you all for participating in the Solutions to Diabetes in Black Americans webinar. Our hard to reach populations, really hard to reach. As I mentioned before, we'll be following up shortly with an evaluation survey, and I'll be sharing a video of this webinar as well. And if you do have any questions for our panelists, you can share them with me, and we can follow up offline and certainly share those results with the participants. Once we make the webinar available online, you also will be able to share those with any other researchers that might be interested as well. That was one of the questions that I did get on the Q&A, so I definitely wanted to make sure to follow up with that. Thank you again, our panelists, for your perspectives, for your unique experiences in the communities that you work with. I hope this was an enlightening and a helpful conversation this afternoon to all those who participated.